Recording in progress.
Good evening to all. So I welcome you all to the first webinar of Lung and Ally. And we have the cardiovascular system today, which is the most important ally of the pulmonary medicines, as far as pulmonary medicine is concerned, because of the huge morbidity and the mortality burden which the cardiovascular system has as far as the chronic respiratory disease is concerned. So I'm presenting a common case of a COPD patient who came with acute worsening for evaluation. It was diagnosed with COPD 12 years back. It is a case of an elderly 86-year-old female with a history of significant biomass exposure for 20 years, which was quit 15 years back. She was diagnosed with COPD and was on dual bronchodilator therapy since 2014. She is a known case of diabetes mellitus on metformin and sitagliptin, along with she is a known case of hypertension on metoprolol 50 mg per day for 10 years, and she is controlled on oral therapy. She presented to the OPD with worsening of shortness of breath, that was MMRC grade 3, with cough and expectoration since 10 days. And she has a history of viral 2 weeks ago and took azithromycin for the same for 5 days. We did a chest x-ray for this patient, as you can see on the right hand side, showing cardiomegaly and some interstitial shadows. We will be moving on. So the patient was overweight with a BMI of 29. She was Dyspneic with a SpO2 of 93 on room air, pulse was 95 per minute, BP was 110 by 70 mm of Hg, respiratory rate was 28 per minute. She was afebrile with no pedal edema, no neck vein engorgement. Chest was bilateral, having V's and a few scattered crackles on auscultation. However, the cardiovascular auscultation was normal. Rest of the examination was within normal limit. RBS was slightly increased to 160 mg per DL. The ECG showed a LVH with strain pattern. A 2D echo was done showing left ventricle normal in size with an ejection fraction of 55%. There was mild concentric LVH. Right ventricle was normal in size and function. There was no evidence of any pulmonary artery hypertension. CBC, LFT, KFT, no routine investigations were within normal limit. So the patient was started on nebulized Saba-Sama 6 hourly along with IV methylprednisolone 40 mg per day. She was also given antibiotics, amoxicillin clavulanic acid, 1.2 gram IV 8 hourly. For blood sugar, she was managed with insulin on sliding scale that was added. However, the patient has only partial improvement in respiratory distress and she required NIV, which was initiated. So we have a case of COPD with acute worsening and cardiomegaly who responded minimally to the Saba-Sama therapy and steroids and was started on NIV. This is what we will be discussing later on. I'll now share the MCQs. So the audience can now fill the MCQs. There is a questionnaire and there are prizes for the winners as already shared. So the first MCQ is, what percentage of patients with heart failure have heart failure with normal ejection fraction? Is it 10%, 20%, 40% or 50%? Second MCQ, which of the following is a key mechanism by which chronic lung disease contribute to heart failure with preserved ejection fraction? Is it the direct myocardial damage? Is it due to pulmonary hypertension? Is it due to inflammatory cytokine release? Is it due to obesity and insulin resistance? The third MCQ, what is the most common symptom which is shared by both the chronic lung disease as well as heart failure along with preserved ejection fraction? Is it hemoptysis? Is it fatigue or chest pain or wheezing, which is the most common symptom? Fourth MCQ, which of the following imaging findings is the most suggestive of heart failure with normal ejection fraction? Is it left ventricular hypertrophy, dilated left atrium, a normal sized left ventricle with a diastolic dysfunction, or is it right ventricular enlargement? Fifth MCQ, in heart failure with ejection fraction, what would be the expected finding on an MRI of the heart? Is it normal left ventricular size with a thickened myocardium, normal ejection fraction with impaired myocardial relaxation, evidence of myocardial infarction scars, or left ventricular hyperdynamic function? The last MCQ is, what does the left atrial enlargement on the echocardiography typically indicate when evaluating a case of heart failure with preserved ejection fraction? Does it denote acute heart failure, diastolic dysfunction and increased left ventricular filling pressure, pulmonary embolism, or aortic valve stenosis? So please fill the MCQs and we'll now carry on. Thank you.
Sir, you are muted.
So Dhruv, you can go back to your case and pose the questions which were, normally you see a bedside when you see a case like, which is like a very routine case in our practice.
Right. So routinely, the questions which we encounter are when and how to suspect a comorbid heart failure, how best to treat a cardiac comorbid COPD, how to suspect associated coronary artery disease in such patients and what tests to order. And coronary calcifications have been mentioned in the Goal 2026 for evaluation of COPD. So what is the significance of these coronary calcifications?
Basically on the clues to think that cardiac comorbidity exists. So we can go ahead now with the three presentations. You can pull down your screen and So I am presenting this on behalf of Dr. Sushmita Roy Chaudhary, who's supposed to be there today, but as I said that because of certain things she couldn't manage today, I'm going to be talking about lungs and heart. When we have such kind of COPD patients, how to look after the cardiac care or to get involved with the cardiac management also in such situations. So primarily heart and lungs are fundamentally linked, and this we know it from 17th century when we knew that both of them work in sync. So COPD and heart failure are the two global pandemics actually. So if you look at the present data, it's a huge burden of these two diseases together, and they are happening in our arena because we as pulmonologists see huge of COPD population and they come with comorbid heart failure. How much we miss. This is something which is very important figures for all of us to remember, that 30% of heart failure patients have got COPD and 30% of COPD patients do develop heart failure. So what it means is there is an overlap which involves nearly one third population of COPD patients which we see. Try to put this number into your daily practice. What it means is every third patient who comes to you with COPD has got associated heart failure. And there is a huge diagnostic as well as a therapeutic gap here. Because spirometry is not performed nearly in one third of heart failure patients who have got COPD. So this is primarily coming from the cardiac practice. But also therapeutic gap is in the form of non-use of beta blockers. They are primarily patients of COPD and from the scare of using beta blockers, which is more so in asthma. But then a lot of COPD patients are also denied of beta blockers. So there is a gap in the diagnosis as well as the management when these two diseases occur together, which is one third of the population of each one of them separately. It is so common that one third of get this overlap? Because of the common risk factors which produce heart failure as well as COPD. So age, elderly, poor diet, sedentary lifestyle, genetics, comorbidities, air pollution, occupational hazards, and very important, smoking. All of these together are the common denominators which try to produce effects in the lung in the form of COPD and on the heart in the form of heart failure. So these are the figures which are like, I think if you want to take a snapshot in your mind, please take it how common it is. We know that 70% of heart failure which occurs in COPD patients is actually with preserved ejection fraction. And we are conventionally heavily dependent on an echocardiography to tell us, which will only be able to tell us those who have got a low ejection fraction. And you can see that there is a new terminology which has come, which is called mid-range ejection fraction, where it is around 45 to 55. And this is again a very common thing which happens in 12% of heart failures of COPD. 16% are preserved ejection fraction, which is, Dr. Samir is going to talk about it, which is above 55% and above. The 12% are mid-range between 45 to 55, and only 11% are less than 40%. Only 11%. So what it means is, if we are looking for a reduced ejection fraction heart failure in COPD patients, we'll be seeing only 1 out of 10 and missing out another 2 to 3 of them. We need to open our minds to understand this overlap. So as I previously said, that which are the patients who are likely to get overlap because of the common risk factors. They are elderly, more female, with more comorbidities, more cardiac issues, and also equally important is those patients who have severe heart failure are more at risk to have an overlap syndromes. What does it lead to? It leads to more risk for cardiovascular death, first heart failure related hospitalization, recurrent heart failures, and of course it will all ultimately lead to increase in all cause death. And this translates into hospitalizations, more deaths, which is the ultimate of demise of the patient of COPD, not from COPD, but from heart failure. So why we miss this? Because the COPD, which elevates the risk of cardiopulmonary events such as exacerbations or major adverse cardiovascular events, are generally with overlapping features. So most commonly, we are so overwhelmed by their pulmonary pathology that we frequently overlook the underlying cardiac comorbidity which is happening. Also, very importantly, there is a complete lack of comprehensive therapeutic guidance or current guidelines to manage these patients who have overlap of COPD and heart failure, which is normal ejection fraction heart failure. No guidelines for there. Why does it happen? It happens because we know that the patients of COPD have increased cardiopulmonary risk, and the primary three drivers of increased cardiac risk or increase in cardiac failure incidences in patients with COPD are related to lung inflammation, lung hyperinflation, as a consequence also leading to hypoxia, which can also produce pulmonary hypertension. So exacerbations, which are precursor of pulmonary and cardiac events, are a catalyst for increasing inflammation, increasing hyperinflammation, increasing hypoxemia. So every exacerbation brings in a cascade which goes over and over again, bringing more inflammation, more hyperinflation, and more hypoxia in this group of patients. And this all leads to more impact of COPD on not only the heart, but also on the pulmonary circulation. So pathogenesis is quite complex, if you see here, and it is definitely bidirectional. When we have a emphysema, we have vascular remodeling, pulmonary artery is thick, elastance is increased, and pulmonary vascular resistance is all going. But we also have airflow obstruction, which causes air trapping, diaphragmatic dysfunction, increase in intrathoracic pressure, and decrease in venous return. What it leads to? Airflow obstruction leading to decrease in RV preload as well as fall in cardiac output. And when we have emphysema, the primarily effect on pulmonary artery leads to increase in mean pulmonary artery pressures, which leads to increase in afterload in the RV. So RV is going to be loaded from both the sides, preload as well as afterload, because of the airway obstruction and emphysema, which are the features in COPD patients. And this leads to complete uncoupling of right ventricle with pulmonary artery. The major drawback here lies in that in echo, where we use to pick up what is going on with the heart, has a very poor acoustic window in respiratory patients. So 50% of patients of COPD do not give an adequate access for a good echocardiography. So what happens to them after the first acute exacerbation in COPD? I think that's a very important thing, that there is increased cardiovascular event, and this persists after the acute exacerbation is gone, even up to 1 year. You can see that even after completing 1 year, there is still significant higher risk of having a cardiovascular event in a patient who has COPD with acute exacerbation in last 1 year. So this COPD acute exacerbation is a risk factor for a coronary artery disease. Then there is a confusion how to treat it. This is the very frequently missed part when we treat the patients of COPD with some suspicion of heart failure, because there is a question about, we are using beta agonists to treat their airway obstruction, and we require beta blockers to look at their heart rate. What happens if you do a beta 2 blockade by using beta blockers? So most of the times, this is a question which is very important for asthma, not for COPD. But what does the beta 2 blockade does? So it decreases the FEV1, FVC in asthma. It decreases alveolar clearance, which leads to decrease in diffusion capacity. It decreases the chemoreceptor sensitivity, which decreases the VE/VCO2 slope, indicating that there is a gas exchange abnormality happening in this group of patients. So management of cardiac comorbid patients puts real challenges in practice. What you need to use is the triple therapy. And we use triple therapy where LAVA is now highly selective beta 2 receptor agonist, doesn't trouble the beta receptors on the heart. LAMAs, which have been shown to be more safe and give more symptom relief. We use inhaled corticosteroids, which decrease the systemic inflammation too. And of course, there are now evidence that they are cardiac safe and do benefit the patients with comorbid cardiac condition. These are the trials which have shown. I'm not going into detail of anything, but the trials of tiotropium, which is a LAMA, which uplift and tiosphere, did show that there is a reduced risk of heart failure and MI and a high cardiac safety in using tiotropium. So clear signal not to be scared of using tiotropium in them. But very importantly, LAMA and LAMA. Tornado and COPD heart failure trial had the cardiac patients, cardiac comorbid patients with heart failure, and in fact they showed that a dual bronchodilator improves the cardiac index by deflating the hyperinflated lungs. This is the deflation study which we know about, and it has shown that dual bronchodilators do help in patients with associated cardiac comorbidity in COPD. Inhaled corticosteroids, there is a UK cohort of more than 1 lakh patients from their data, which specifically showed that use of inhaled corticosteroids in COPD patients with cardiac comorbidity leads to lower rates of heart failure hospitalizations. And then on the top of it, the triple therapy in IMPACT and ETHOS shows that it reduces all-cause mortality in patients who have nearly 1/3 of these patients had cardiac comorbidity with COPD. So the data is clear that all three drugs which we use in our practice for managing the patients of COPD, even if they have associated comorbid heart failure, all the drugs are safer. And on the other hand, there is something to suggest that they have salutary benefits in using, particularly in the group of patients who are having comorbid cardiac conditions. So the question is, what cardiac treatment can improve the further outcomes in this patient? So I'll leave that because it will be taken up in the next talk. I have to t-shirt. I'm not able to. I'm not able to stop this presentation. Can somebody from the back end discontinue this? Discontinue my screen? Can somebody from the back end can do that?
Yes, sir.
Yeah, please remove this. I'm not able to do it. I do not know why. Stop share is not coming. Okay, got it. Yeah, got it. So I think now I'm no longer, my screen is not visible anymore. Is that right?
Yeah.
I've stopped shared, right. So I think this is just a kind of presentation which is supposed to bring some thoughts in mind. So this is a food for thought, which will go for the panel discussion later on. But now we have two more very important presentation. The second one is, what are the imaging clues which can help a pulmonologist to pick up that there is something going on wrong with the heart side also in a patient of COPD. And it will be taken by none other than Dr. Khushbu Pilania, whom we all know is a radiologist who's dedicated so much time and her energy in pulmonary and in pulmonary system. So can you play the Dr. Khushbu's presentation now? The backend team?
Yes, sir. Doing that.
Okay. So I think, Aziz, as you would have seen this kind of figures, I think we can start with straight away that it seems that, we must be missing a lot.
Yes, sir. So probably we will be missing many heart failures during our routine practice when we see the COPD patients. So mostly what we do, we'll do, and for who are patient who are admitted with dyspnea, we may perform an echo and we see a normal ejection fraction. Mostly we'll be happy that the heart is okay. And many times our cardiologist also tell his echo is normal and he's okay. But we feel that the patient is still dyspneic and the patient may improve with a bit of diuretic also.
Correct.
That we do usually do in our practice, even if the echo is not showing any fall in ejection fraction. But we have to be aware of this entity called this heart failure with preserved ejection fraction.
I think that's the precise reason we brought this topic today, because this is most frequently overlooked, not only by pulmonologists, but by cardiologists also
Yeah, yes,
themselves.
sir.
Because
They
they will
will
look
also
at the
tell
echo
echo is
report
normal,
and they
yeah.
will say, yeah, it is fine. Why do you want to worry about this patient? This has got nothing to do. And most of the time, they're not bothered about the heart failure part. They're bothered about the coronary artery disease. That echo is perfectly normal. Why do you want to think of anything else? This is COPD, treat your COPD. So I think that was the precise reason we got even a cardiologist on board. So carry on and start the presentation of Dr. Khushbu, please. Yeah.
Hi, a very good evening, everyone. At the outset, I would like to thank Dr. Deepak Talwar sir and the entire PACS community for having me here. It's always a huge pleasure and great learning with PACS. The energy that is created around the various cases is always phenomenal. So what I'll be talking today is the imaging clues for heart failure in patients with lung diseases. So as we all know, there is the presentation of a heart issue and a lung related issue often overlaps. So when a patient who already has some kind of a lung issue comes in exacerbation, there is a dilemma that whether it is progression of the lung disease itself or some concomitant cardiac issue has propped up. And obviously, sorting that is of prime importance. Now, there are two ways in which we see this interaction between lung and heart. The first cascade or the first pathway is wherein there is a primary lung involvement in cases like COPD or interstitial lung disease, which increases the resistance within the lung tissue, further increasing the pulmonary arterial resistance, and then it involves the heart secondarily, and due to that heart involvement, the exacerbation often happens. The other pathway is where there is concomitant involvement of the lung and heart due to some systemic process. Maybe they can be involved at different points of time, but the involvement is not secondary. It's a primary involvement of the heart, which may manifest with exacerbation of symptoms. So let's see how these pathways work, which will help us understanding how the imaging pattern can help us, number one, recognize an early heart failure and also recognize what is the pathway. So whether the heart failure is secondary or the heart issue is secondary to the lung issue or it is a concomitant involvement. So it's a simple pathway where we understand that any chronic lung disease like interstitial lung disease or COPD increases the pulmonary vascular resistance, leading to a pulmonary arterial hypertension, the group 3 category, which further leads to a right heart failure, and that eventually ends into a global heart failure. So the imaging timelines are similar. So in the first phase, you start developing a pulmonary arterial hypertension where you start seeing a dilated pulmonary artery and peripheral pruning of the smaller vessels, followed by increased strain on the right heart, where you start seeing features of right heart strain, that is dilation of the right ventricle, then septal flattening. Over time, this right heart strain leads to a generalized congestion in the body in the form of dilation of the IVC, contrast reflux into the IVC, finally leading to a kind of global heart failure where the left heart also stops functioning, and that leads to a pulmonary edema kind of a state. So these findings are what we see in this cascade on the HRCT, and we need to pick them up early to be able to differentiate whether what we are dealing with is an exacerbation of the lung issue or there is a concomitant heart issue that needs to be handled. So as we discussed that in the early phases of the heart involvement due to a lung disease, in the pathway 1, you start seeing a pressure overload symptom. So due to increased vascular resistance in the lung parenchyma, the main pulmonary artery starts dilating with right heart strain. So these lead to very specific imaging findings where you start seeing this dilated main pulmonary artery. There are criteria for this dilation. So either you measure the diameter at this axial section where you see this Y of the pulmonary artery and this aorta sitting on top of it as a round structure, measure the pulmonary artery diameter at this site, measure the aortic diameter at this site. If this ratio is greater than 1, you should raise a concern for pulmonary arterial hypertension. A cutoff of 29 millimeter for pulmonary artery diameter, irrespective of the aortic diameter, is also considered as suspicious for pulmonary arterial hypertension. Then as it progresses, we start seeing a right heart strain or dilation of the right heart. So we should know that normally in a normal individual, the left heart or the left ventricle is always larger than the right ventricle. When you start seeing a right ventricle, which is more dilated, so you see a right ventricle which is much more dilated than the left ventricle, that means we are dealing with a right heart strain or an impending kind of a right heart failure. Then this IVC. So most of the times you do not see a contrast into the IVC during the pulmonary angiogram phases. A contrast in IVC in pulmonary angiogram phases means it's a reflux. So if you see a reflux, that again says that we are into a congestive or a pressure overload state, and this patient is developing a pulmonary arterial hypertension with right heart strain. So these are the early signs which tell us that this is ongoing, which may eventually convert into maybe a global heart failure and other issues as well. So once that global heart failure sets in, the left ventricle also starts decompensating. Then the lungs start getting congested. The congestion in the lungs is seen as pulmonary edema. So what do we see in pulmonary edema? It's a fluid overload state wherein in the pulmonary interstitium, you start seeing the septal thickening. So all of these lines that you see all over the lungs are septal thickening. How do we differentiate it from ILD? We've been discussing it over and over, that these are smooth septal lines. Number one, they are not irregular. There is no architectural distortion in the background lung, and you see this pleural effusion. So very seldom with ILD do you get pleural effusion. So when you see pleural effusion, look for the septal line. If there are smooth septal line, think of pulmonary edema. Similarly, these septal lines are often seen towards the apex, as against the routine interstitial lung diseases like UIP, NSIP, where you'll see a basal predominance. In the pulmonary edema, you also see these smooth septal thickenings towards the apex. So when you see this, again, think that you might be dealing with pulmonary edema. They often happen towards the apices before they happen towards the bases. So apart from these smooth septal thickening, the other ways in which the pulmonary edema presents is patchy peribronchovascular ground glassing. So like a picture like this. Or it may also present with confluent peribronchovascular nodules or patchy peribronchovascular consolidation. So we need to understand that none of this is pathognomonic, but in the appropriate clinical settings, there is a suspicion of pulmonary edema. These are the imaging manifestations. So they should not be overread as infection or maybe malignancy or an interstitial lung disease, because these are very much known imaging manifestations of pulmonary edema. So is the crazy paving. So often if in a patient where there is a strong suspicion of pulmonary edema, if you see such a pattern, don't say that it's a crazy paving and hence pulmonary alveolar proteinosis. Yes, it's a crazy paving, and over time we've realized that crazy paving is a pattern which is not just seen with pulmonary alveolar proteinosis, but with a large number of differentials, of which pulmonary edema is also one of them. Then another thing that we often see in a patient with pulmonary edema are the mediastinal lymph nodes. So again, this is a mimic, because once you see a mediastinal lymph node, patient has come with exacerbation, there is a suspicion that maybe this is an infection setting in, whether that is causing the lymphadenopathy. But if there are signs of pulmonary edema, there are signs of heart failure, these lymph nodes are known to occur in patients with pulmonary edema. So we should know this fact, and just the mere presence of a lymph node should not tempt us towards tilting our diagnosis towards an infection. It can very well be a concomitant infection, but at the same time, these are known to occur with pulmonary edema. Then this peribronchial cuffing. So when you see this halo around the bronchus, this is again peribronchial edema due to the congestive symptoms that happen due to pulmonary edema. That was how the pathway one, where the heart involvement was due to the lung, manifested on imaging. The other pathway is where the lung and the heart are both concomitantly involved. So there are a large number of disease processes which involve both these structures concomitantly, like sarcoidosis, amyloidosis, and CTD-ILDs. So often in these cases, it is not just a group 3 pulmonary hypertension subtype, but both the heart and the lungs are involved, maybe simultaneously or at different points of time, but by a primary process. So how do we differentiate these two pathways? So as we understood that in pathway 1, there was lung disease followed by increased vascular resistance, pulmonary arterial hypertension, right heart failure, then global heart failure, and pulmonary edema came in late in the picture. However, in this pathway 2, wherein due to a systemic disease, there is concomitant lung and myocardial involvement leading to right-left ventricle dysfunction, the pulmonary edema comes in early. So the key insight is that if you see pulmonary edema without pulmonary arterial hypertension, then think of primary myocardial involvement. If there are signs of pulmonary arterial hypertension, right heart failure leading to the entire spectrum, then this definitely means that the heart involvement is secondary to the lung involvement. What often helps is the cardiac MRI. So we will see cases where we realize that the primary myocardial involvement is often picked up phenomenally by cardiac MRI. Things like sarcoidosis, amyloidosis, even CTD-related myocardial scarring are picked up beautifully. They help us make the diagnosis with confidence and also start the treatment accordingly. So these are a few case scenarios which will, substantiate what we have been discussing over the while. So this was a 44-year-old male, treated case of sarcoidosis, presented with new onset tiredness and dyspnea on exertion. Obviously, the first thought was that relapse of sarcoid, and a chest X-ray was, chest CT scan was done, which was absolutely normal. So now the question was, what should we be doing the next? Obviously, the symptoms are there and we need to figure out what could be the cause of that involvement. The question is whether it could be heart. So we did an ECG and we realized that the ECG was normal, following which we did a cardiac MRI, and on the late gadolinium enhancement, we could clearly pick up these areas of mid-myocardial fibrosis, which are very typical and characteristic of sarcoidosis. It could be very clearly pinpointed that the current symptoms are due to this heart involvement, and when it's a heart involvement by cardiac heart involvement in a case of sarcoidosis, it needs to be treated really fast. Another similar case wherein it was a 55-year-old female with recurrent transudative pleural effusions. We could not figure out a cause of those pleural
Recording
effusions.
stopped.
On further workup, as a part of figuring out the underlying diagnosis, an echocardiography was done which showed preserved EF. A pro-BNP was done, but it was raised. So it was a heart failure with preserved EF and recurrent pleural effusions. That again raised the antenna, and we thought of doing a cardiac MRI. On the cardiac MRI, we saw this characteristic altered kinetics. So this is the left ventricle, and you see that the signal of the left ventricle is not following the normal norm, wherein we see the nulling of the myocardium in a very specific manner. So this raised a concern. We did the delayed late gadolinium enhancement. There was heterogeneous enhancement of the entire myocardium. And this was very characteristic of amyloidosis. So this was a case of systemic amyloidosis with cardiac involvement, and everything fell into picture. So the patient had a lung disease, but there was a concomitant cardiac involvement, which we could pick up to figure out how to handle the patient further. So this will be one of the last cases where, again, it's an interesting example where a patient, 65-year-old female, known case of hypersensitivity pneumonitis, on treatment came up with acute exacerbation. The obvious questions was it a flare-up of hypersensitivity pneumonitis? Is there some superimposed infection, or is there anything else? What is causing this flare-up? A CT scan chest was done, which said that there are changes of hypersensitivity pneumonitis in the lungs, but at the same time, there is a lymph node. Because there was a lymph node, she was 65. The patient was very, anxious on what is happening. A PET CT scan was done to assess whether the lymph node is active. It showed good uptake, and a biopsy was planned. When the patient was planned for biopsy, prior to this, on an MDT discussion, we reviewed the images. So yes, the lung parenchyma shows a fibrosing ILD. The pattern is consistent within hypersensitivity pneumonitis. We have seen these air trapping interstitial irregular septal thickening, but something wasn't fitting in well. We went toward the lower sections, and overlapping these areas of mosaicism, we see the smooth septal thickening. So all of this is the smooth septal thickening overlapping it. You saw the mediastinal window, something that you missed on the lung window. You could see bilateral pleural effusion. So pleural effusion and septal thickening on a background of hypersensitivity pneumonitis. This was thought to be pulmonary edema. Patient was put on diuretics and she responded really well with respect to the acute exacerbation. So this was a hypersensitivity pneumonitis with heart failure due to a prior coronary artery disease with resultant pulmonary edema causing the new exacerbation. So that's all we have for today. The take-home messages are not all dyspnea is pulmonary, which you know better. CT scan chest can pick up a few subtle findings that can raise your antenna towards an ongoing cardiac issue. Look beyond lungs, look at hearts. Cardiac MRI is an excellent tool to look at hearts and figure out what's happening there. Thank you.
Thank you, Khushbu, for bringing in beautifully that, we have been thinking all the time that MRI has no role in respiratory medicine, but we are breaking all barriers today. The cardiac MRI has opened a new doors to diagnosis of unresolved puzzles and queries, and one of them is heart failure related, which you have beautifully shown in the last couple of cases where cardiac MRI helped a lot. So I think this point will be taken by Dr. Sameer Gupta also, who is going to talk about cardiac from the cardiac side on normal ejection fraction heart failure. So we'll go quickly to the third talk, which is by Dr. Sameer Gupta, who is a senior cardiologist and director of Cardiac Cath Lab Metro Hospitals. So we go for the next presentation. Second team, can we start? Yeah. So,
hello everyone, I'm Dr. Sameer Gupta, and today we will be discussing one of the most challenging and evolving areas in cardiovascular medicine, which is heart failure with preserved ejection fraction. Now, for decades, we've not really had much in terms of treatment options, but a lot of that has changed over the last few years. And over the next few minutes, we'll take you through the journey of what exactly is heart failure with preserved ejection fraction, why does it happen, how do you recognize it, how do you diagnose it, and now how do you treat it. So, HFpEF is basically a condition where you have, it's a comorbidity-driven inflammation. And for the definition of heart failure with preserved ejection fraction, you need the symptoms and signs of heart failure, which is basically shortness of breath, dyspnea on exertion. You need to have an ejection fraction of more than 50% combined with some structural and functional abnormalities. And this is really important because almost 50% of all heart failure cases and mortality is similar to, the mortality rates are similar to heart failure with reduced ejection fraction. You know, where your EF is 30%, 40%, 25%, that's heart failure with reduced ejection fraction. And heart failure with preserved ejection fraction is when you have symptoms and signs of heart failure, but your ejection fraction is more than 50%. Now, the epidemiology of heart failure with HFpEF is also very striking. Over 50% of all heart failure cases are now classified as HFpEF, and the prevalence is rising by approximately 1% a year. And this is driven because of the aging population, the rising burden of comorbidities like obesity, diabetes, hypertension, and there's a strong female predominance as well, with almost 60% of HFpEF patients being women. The median age of diagnosis is 70 to 75, and the 5-year mortality ranges almost in 50 to 75%, which is comparable to heart failure with reduced ejection fraction. The hospitalization rates remain very high despite advances in care. And this number should dispel any notion that HFpEF is a mild condition. And now the key concept is that HFpEF is not a single disease. It's a syndrome which encompasses multiple overlapping phenotypes. And this is precisely why the one-size-fits-all approach that historically has failed. Look at the phenotype of the patient. The major phenotype include the cardiometabolic phenotype, which is driven primarily by obesity and diabetes. Then there is another phenotype of patients which are atrial fibrillation predominant phenotype, and the right heart or pulmonary vascular phenotype is also there. Patients often straddle multiple groups. It's not that you're isolated. Often these patients have multiple comorbidities and then they overlap one and the other. And the phenomapping, we've really learned a lot because of this phenomapping and identifying these patients with different phenotypes. And this is why phenotype guided therapy is the future. And we'll talk about that shortly. The most common phenotype you see is the garden variety HFpEF driven by comorbidities like hypertension, which is almost in 90% of cases. Obesity and overweight account for almost 80% of the population. Diabetes and chronic kidney disease are strongly interlinked risk factors. And the key insight here is that comorbidities are not just bystanders, they're actually active drivers of the myocardial dysfunction to inflammation. And in fact, the population attributable fraction for obesity is actually higher in HFpEF as compared to HFrEF. And the multi-morbidity burden correlates directly with the severity of inflammation and actually clinical outcomes as well. Atrial fibrillation and vascular aging represents another critical etiology pathway. Like we said, the different phenotypes. So there's an AF phenotype of patients. And what happens over here is there is vascular stiffness that happens. The arteries, they kind of harden up. And that increases the LV afterload and pulse pressure. And this precedes and promotes actually diastolic dysfunction. So your heart function, your heart, when you think about it, has got two different functions. One is the systole, where your heart actually contracts and you get the ejection fraction. And then when your heart relaxes, that's called the diastolic phase of the heart. And if that part stiffens or it's not relaxing properly, that is when you start seeing diastolic dysfunction that you see on your echo reports as well. And this diastolic dysfunction increases the LV pressure and can lead to shortness of breath and is a predisposing factor for heart failure with preserved ejection fraction. When you have atrial fibrillation, the atrial kick that you get in the diastolic phase to fill the left ventricle, and that reduces dramatically, and that leads to a backflow of blood, leading to pulmonary vascular congestion. Another thing that happens with atrial fibrillation is you develop chronotropic incompetence. That means your heart rate is not increasing the way it should when you exercise, and that limits your exercise capacity as well. So understanding this bidirectional relationships is very essential when you think about atrial fibrillation. When you think about, heart failure with preserved ejection fraction. But not every preserved ejection fraction is a garden variety HFpEF. We must also rule out the things that can mimic it, like cardiac amyloidosis, hypertrophic cardiomyopathy, and even sarcoidosis. So they can independently cause, they may have a normal heart ejection fraction, but they can have some relaxation abnormalities, some changes in the heart that can lead and predispose to HFpEF, with its heart failure with preserved ejection fraction. And that is where some of the more advanced techniques like cardiac MRI, PET can come into play. So I think this slide really illustrates the central inflammation paradigm that ties the entire pathophysiology together. Comorbidities like obesity, diabetes, they drive systemic inflammation. And there's an increase in IL-6, TNF-alpha, that further leads to endothelial dysfunction, reduced nitric oxide bioavailability. And the final downstream effect is that your myocytes in the heart, they stiffen due to titin and interstitial fibrosis. And this cascade from systemic inflammation to myocardial stiffness was a hypothesis that came out in 2013. And this is the predominant pathophysiological framework when we think of heart failure with preserved ejection fraction. And that's why anti-inflammatory therapies, as we speak, are currently being investigated. Like I said, the hallmark is impaired relaxation of the heart, plus passive stiffness. So the net result, and this is what you're seeing over here, is a pressure volume curve, and I don't expect all of you to understand it. But what I basically want to show over here is that the net result is elevated LV filling pressures. And these pressures rise even sharper when you exercise. So this is the normal thing with the normal pressure volume curve over here. And in somebody who's exercising, who has HFpEF, this pressure goes up dramatically. And this sharp rise in pressure is something that you see in HFpEF patients. And this basically leads to pulmonary congestion, dyspnea, exercise intolerance, especially with tachycardia, hypertension, volume overloading, and even with atrial fibrillation. And basically this slide reinforces that HFpEF is a multi-system disease, not just a cardiac problem. It involves the heart, the lungs, the kidneys, the skeletal muscle. This multi-organ involvement is precisely why single target therapies have historically failed, and why a multi-pronged approach to therapy is to treatment is actually very important. So the question comes up, we've kind of understood what the different phenotypes are. We kind of understood when it happens, but when should you start suspecting it? And I think the classic presentation is exertional shortness of breath in an older female with a background of hypertension, obesity, atrial fibrillation. And the clinical pearl is that, orthopnea and PND is specific to cardiac etiologies. As pulmonologists, you're seeing a lot of COPD, ILD, bronchiectasis, but the classic cardiac shortness of breath from heart failure is orthopnea and PND, and they are very specific to cardiac etiology and rarely seen in other conditions. Yeah. So the clinical features of HFpEF, they actually span a spectrum. The cardinal symptom is exertional shortness of breath and exercise intolerance. The congestion phenotype presents with peripheral edema, elevated JVPs, crackles, orthopnea, and there's a low output phenotype as well, where your heart is not able to pump out enough blood. And that can lead to fatigue, cognitive clouding, pre-adrenal azotemia. And there's a condition called bendopia, which is breathlessness when bending forward. Now, this is very specific, but not very sensitive. And it's an often overlooked sign, but this has to be taken with a pinch of salt, because somebody who's obese and he's bending down, he may not have HFpEF, but just the sheer pressure of the fat going up into the lungs, into the pressing on the diaphragm, may not allow them to take a breath. And that can also lead to shortness of breath. So this has to be taken with a pinch of salt as well. But importantly, the quality of life scores in HFpEF patients are often worse than with HFrEF, which underscores the clinical burden of this syndrome. How do you work these patients up? History is of paramount importance. You look at volume overload signs, you see functional capacity, the NYHA class, or you do get an ECG on these patients, you look for atrial fibrillation, whether they have LVH, left axis deviation. On the lab work, you get an NT-proBNP, CBC, creatinine, the usual good stuff, and then an echo, which is kind of the cornerstone of diagnosis in these patients. And what are we looking for on echo? On echo, we are looking at a left atrial volume index, which is often called as LAVI, something more than 34 ml per meter square. It is a marker of chronic congestion. That means, we often call the left atrium as the barometer of the pressure in the LV, because if your LV pressure is high, your left atrium by backflow is going to be start getting enlarged. We look at hemodynamics. We look at the TR jet, the tricuspid regurgitation jet, and that is kind of what you see in pulmonary hypertension as well. So if your TR jet is more than 2.8, that usually signifies your pulmonary artery systolic pressure is more than 35. In the myocardium, we look at myocardial strain. This is not very commonly done, but is also a marker of overall heart function. And the other thing we see is an E to E prime ratio of more than 9, which signifies elevated LV film pressures. NT-proBNPs are very commonly done, but we have to understand what are some of the things that can increase and reduce the NT-proBNP in spite of there being no heart failure. So, something that rules in is an elevated NT-proBNP supports a diagnosis, which is more than 125 in somebody with sinus rhythm. But if you have atrial fibrillation, renal failure, if you are increasing in age, you have pulmonary embolism, then these conditions can increase the NT-proBNP, but they don't always they are not always significance of heart failure. And on the flip side, in obesity, and if you're taking androgens, your NT-proBNP may be falsely low, This is something we see fairly commonly. In fact, the other day I had a very obese patient who came and we were suspecting heart failure and the patient had a normal NT-proBNP. So, this can be falsely low in patients who are obese. So to try and kind of really diagnose patients with HFpEF, we now have the HFpEF scoring system, where a score is defined for H stands for heavy weight, where if your BMI is more than 30, you get 2 points. The second H is hypertension. So if you're on 2 medicines, you get 1 point. 2 medicines for hypertension, you get 1 point. Atrial fibrillation, whether it's paroxysmal or persistent, atrial fibrillation, you get 3 points. Pulmonary hypertension gets 1 point, and then older age, which is more than 60, you can get 1 point. And depending upon what your score, and the last is F, the HFpEF. F is filling pressures. And if filling pressures, if your E to E prime is more than 9, you get an additional point. So total of 9 points. And depending where you are on the scoring system, it helps to screen whether you have HFpEF or not. So the more the number, the higher the probability. An intermediate score is anything from 2 to 5. And if your score is 0 to 1, the chances of you having HFpEF is fairly low. So when you work these patients up, you do a pre-test, you run a clinical exam, you've got the NT-proBNP, you've done the echo, and then you get a HFpEF score. If your HFpEF score is more than 5, then it's diagnostic. But still you're not convinced. There are these patients who are in the gray zone and you're not convinced. The diagnosis is more than 5. Is from 6, but if your scoring system is 5, if your HFpEF score is 5, you're like, yeah, there is something wrong. I want to investigate this a little bit further. So for these gray zone people, an additional option which is available is the diastolic stress test. And here you're looking at your exercise wedge pressure going more than 25. Now I'll try and simplify this. Your wedge pressure is the pressure of the heart when the heart is relaxing. Okay? Your wedge pressure is the pressure in the heart when your heart is relaxing. A normal wedge pressure is 12 to 15 or lower in some cases. If your wedge pressure goes to more than, even if you're exercising, your wedge pressure should not increase because your heart should adapt. But if your heart is unable to adapt, then your wedge pressure will go up to more than 25. And that is when you start thinking of heart failure with preserved ejection fraction. Now, a wedge pressure is something we diagnose in the cath lab, but otherwise there are some other diastolic stress tests, like you can do a PET scan. PET can also be helpful in this. You can do an echo stress test where you start looking at LV pressures and diastolic pressures in the echo lab. And in the cath lab, what we're looking for, like I said, you look at a wedge pressure, you look at exercise wedge pressure, you look at the slope, you look at the V wave of the aortic tracing. And a prominent V wave indicates a non-compliant left atrium, which I mentioned earlier, like the barometer of the LV. So there are different things that we can do in the cath lab to try and unmask the symptoms to unmask HFpEF. When we treat these patients, we usually have a 3-pronged approach, which is a symptom relief for which diuretics are the cornerstone, comorbidity management, where obesity, atrial fibrillation, hypertension, the drivers of HFpEF have to be treated. And the other are disease modification, where SGLT2 inhibitors are the foundation therapy of these patients. Diuretics have to be very closely balanced in these patients because your goal is euvolemia at the lowest effective dose, because you don't want to over-diurese or under-diurese these patients. So you have to really walk a tight balance in these patients, and renal function, which can often worsen transiently when you start diuretics. We see this all the time. This is something to keep in mind as well. So like I said, we are now transitioning to a treatment landscape, and what a transformation this has been. Before 2021, every major trial in HFpEF was essentially neutral. There was TopCat, CHARM, iPreserve, Paragon, even Paragon heart failure for that matter, which is the sacubitril valsartan combination, ARNIs as we call them. They all failed to meet the primary endpoints, but this was the era of therapeutic nihilism, right? But from 2021, we've entered the era of evidence. Emperor preserved with empagliflozin. That showed a hazard ratio of 0.79. Delivered with dapagliflozin showed a hazard ratio of 0.82. And now even the newer medicines like the newer trials like HPref demonstrated transformative symptoms with semaglutide. And even similar results we've seen with some of the tirazepide and other drugs as well. But another one is the fine arts heart failure, which showed that finerenone had a hazard ratio of 0.84. And this has really been very important, and this kind of allowed the FDA to give approval for use of finerenone in HFpEF in July 25. So the treatment pillars in 2025 are actually SGLT2 inhibitors, finerenone, or MRAs, which is spironolactone, eplerenone, GLP-1 receptor agonists for obese patients, diabetics, and managing their comorbidities. So SGLT, like I said, I'm not going to spend too much time on this slide, but this is just the data of SGLT2 inhibitors, whether it was Emperor, Deliver, and what ends up happening is there's a lot of osmotic, and the thought is that there's some osmotic diuresis. You also lose some weight with these medicines. There might be some increase in nitric oxide, reduction in inflammation, autophagy and promotion, which overall leads to an improvement in endpoints and improvement in mortality and symptoms in these patients with heart failure with preserved ejection fraction. The MRA story actually has evolved a lot from the controversial TopCat trial to the breakthrough fine arts heart failure trial. TopCat was with spironolactone. It was technically a neutral trial with a hazard ratio of 0.89, but it crossed unity. But what we found in that is that the American subgroup showed a strong positive signal at the hazard ratio was lower. And the discrepancy was thought to be because of enrollment issues in the Russia-Georgia cohort. But in fine arts heart failure with finerenone, which is finerenone, as some of you may know, is a non-steroidal MRA. And it enrolled 6,000 patients that showed a significant 16% reduction in total worsening events plus cardiovascular death. And heart failure hospitalization was reduced by 18%, consistent across all subgroups. So finerenone has an important advantage to spironolactone, significant improvement in these patients. This was the first obesity drug to actually demonstrate reduction in heart failure clinical endpoints in this HFpEF population. So what is the clinical algorithm? So you diagnose these patients, everybody gets an SGLT2 inhibitors, which is DAPA or empagliflozin, and that's a class 1 indication. And then you treat the fluid overload with loop diuretics. You can treat obesity with these newer drugs. If your EF is less than 60%, in our lab, we call a normal EF of anything less than 55%. 55% is our cutoff. So if your EF is lower than 55%, then RNAs and mRNAs can come into the picture. And if you have resistant hypertension, then MRAs are very important. This is something I've put over here, which is actually very important. We as clinicians and treating physicians are often seem to be blamed for this as well. But non-pharmacological therapies are very, very important in treating these patients. Supervised exercise training has very strong evidence. It improves the VO2 by 1 or 2 points. And that may be modest, but this does translate into clinically meaningful and significant improvements in quality of life. A 6-minute walk test, NYHA class, and the recommended regimen is combined aerobic training for 150 minutes per week of moderate intensity plus resistance training. And supervised cardiac rehab is also preferred initially. Weight reduction is very, very important. Like I said, a lot of these patients are obese, so weight reduction is very important, whether we do it with drugs, whether we do it with just diet and exercise. That is something that is to be, that we can debate about. But weight reduction is very important. Sodium restriction to less than 2 grams a day helps with volume management, but excessive restriction below 1 gram can worsen the neurohormonal activation as well. Fluid restriction to 1.5 to 2 liters per day is appropriate in decompensated patients. So the comorbidity targeted management is important. Hypertension should be managed with a whole host of drugs. Atrial fibrillation management, diabetes and metabolic syndrome management, anemia and iron deficiency should be connected. And a lot of your patients, obstructive sleep apnea is prevalent almost about 50 to 80% of these patients. So they should be screened and they should be adequately treated as well. So just the final takeaway. That the definition of HFpEF is multi-organ system. It's basically HFpEF is a multi-organ systemic syndrome, which accounts for over 50% of all heart failure patients with morbidity comparable to HFrEF. The pathophysiology goes beyond just simple diastolic dysfunction to more of microvascular inflammation, reduced nitric oxide, and signaling stiffening of the heart. And diagnosis, we should use the HFpEF score, which we talked about over here, and the HFpEF algorithm. And we should exclude amyloidosis, hypertrophic cardiomyopathy, or other conditions that can mimic it. We should do phenotypic guided management. Obese patients should be treated with appropriate drugs. Hypertension should be treated aggressively. If it's an atrial fibrillation dominant patient, then rhythm control is important. And for the RV or the pulmonary hypertension phenotype, we should treat that with dialysis plus SGLT2 inhibitors. And these are some of the evidence pillars that we have as of today. SGLT2 are the first and foremost drugs. There are class
I think
one
it's
in some
finished.
guidelines and 2A in the other guidelines.
Backend.
Finerenone has been approved. And now the newer GLP-1 and the
Hello.
GLP-1 dual agonists, they are also very important in treating these patients, especially those who are obese. And exercise weight loss is a class 1 indication and is consistently and it's profoundly underutilized. So thank you so much. And now let's discuss questions.
Am I audible now? Okay. So I think we had 3 presentations and a case study to link the entire episode on how COPD patients or respiratory patients have a heart failure, which is with preserved ejection fraction. And of course, the new modalities we discussed. We also had a detailed discussion about its diagnosis and management from cardiology perspective. And soon there will be questions related to that. And in the meantime, I think Dr. Khushbu has also joined, so we will be able to take a couple of questions now. But before we go ahead, I think the important thing is that can you bring Dr. Dhruv your case, that what was done to your case, which was started with NIV also, and this patient was breathless. Can you bring back your case? Yeah. So I think you can move on to your last slide where you started with NIV for the patient because he was not responded and you left a lot of questions. So what happened afterwards to this patient? So there are certain investigations you want to discuss about this patient.
So we did the lung function for this patient. And as we can see, the FEV1 by FVC is 54.84, showing obstructive pattern with a FEV1 of 51%, moderate obstruction gold class 2. FVC was 75% with a TLC of 104%, which was normal. However, the residual volume was 158%, and the RV by TLC was also 156%, indicating some air trapping. The DLCO was decreased to 56%. However, the KCO was preserved 99%, indicating a decrease in the VA, which was 58%.
Yeah. So we have CT scans. Dr. Khushbu can have a look at the CT scans. In a short, this patient is COPD patient who came with an acute exacerbation. Echo was not contributing as the ejection fraction was good in this patient. And we have an NT-pro BNP report of 3,954. You can run the CT scans. Yeah.
Lung window.
So you showed us how the pulmonary congestion can be responsible from the heart side. And beautifully, you demonstrated the role of cardiac MRI, which even Dr. Samir spoke about, the new armamentarium into the practice where we have started looking into the cardiac function in patients who come with the respiratory symptoms and lung involvement. I think the specific question would be that, Khushbu, are there on the CT scan any red flags to tell that this patient might be having a heart failure, even if the echo doesn't show? And of course, when we discuss the NT-proBNP result, it does show that there is a cardiac stretch.
So,
You are muted.
yes. I'm sorry. So on the CT scan, we can clearly see that there is mosaic attenuation. These are expiratory images showing mosaic attenuation with prominent pulmonary vessels at places. So the patient is a known case of COPD, and it's the expected airways involvement. The prominent pulmonary vessels is again a part of the component of the airways involvement because I'm not seeing a dilated main pulmonary artery. When I look for red flags for cardiac involvement, there are two things which we are seeing. There is a heart which is globular and enlarged, so we see a cardiomegaly for sure. Apart from that, there is some pericardial thickening, which also raises an alarm that the raised pro-BNP with a preserved ejection fraction could, be something happening within the pericardium or the heart myocardium per se. So, though there aren't any overt signs to suggest either a secondary pulmonary arterial hypertension or a pulmonary edema per se right now, there is nothing obvious to say either of those. But yes, the heart is enlarged and there is pericardial thickening or maybe some thin strip of pericardial effusion also. But I think the echo was normal, so I would say that.
I think that's precisely, Khushbu, we were bringing this question that, how can you address the issue when the echo shows that the ejection fraction is normal? It's basically a diastolic heart failure. So
Yes.
are there any lung signs to tell that there could be a diastolic, although you say echo is fine, but then there is an diastolic heart failure?
So currently, the lungs aren't showing anything specific. Most of the times in these diastolic heart failures, pulmonary edema sets in first, but I'm not seeing anything that suggests a pulmonary congestion for that matter. I think this is an ideal candidate for a cardiac MR to figure out why that diastolic heart failure is.
I think that's the excellent comment, Khushbu, that cardiac MRI would be something which will be in the diagnostic process of such kind of patients who are difficult to be picked up in the routine testings. If this NT-proBNP is not high, I don't think so there is any alarming signal to tell us what's going on in this patient actually. So we move on to the certain questions which we have for the panelists today. And we start with Dr. Aziz, that, the patients are in distress and when they come in acute exacerbation, so not necessarily admitted patients in the OPD, what do you basically, how to suspect? That's the first question. How do you suspect that there is an overlap of something going on from the cardiac side also in this patient? Like what we should look for?
Yeah, sometimes the patients will be complaining that their dyspnea is not subsiding even though they are taking their inhalers properly as we have instructed them. They may be on the triple therapy, but still they are telling they are getting dyspneic on their routine activities. And they may have a bad cough also, which is mostly it is not expectorating this, it will be dry in nature. So that will be irritating them, and that may be they may have difficulty in lying down or sleeping because of the dry cough, which aggravates during the lying down position or during sleeping, so making them difficult to sleep. And also the dyspnea which is not going off even if with the adequate treatment with the inhalers we have prescribed them, and with the strict adherence to the regimens we are going. And in such situations, we have to suspect that it's not only the lungs, but the colleague is also maybe involved, that the heart also may be involved, and we may have to subject to them to the routine test. And a handy investigation will be the echo we usually do, but we may have this result like the ejection fraction is normal. There is no almost abnormality, but we may have. I think it's better to do a NT-pro BNP also to see. That's the initial preliminary investigation we can do to suspect the heart also is involved in this scenario.
I think that's a wonderful comment that, you have to look beyond your lungs when the dyspnea is not being properly addressed despite best of the therapy you are giving. Like in this patient, we started with NIV also to be given to this patient. And Samir showed in his presentation that NIV is also a treatment if they have preserved ejection fraction heart failure, which is related to obesity, sleep apnea, so many other things, because it is going to drive the fluid inside and make the alveolar spaces empty and improve the gas exchange, improve the things in the patient. So Samir, I will ask this question to you, but before that, we would like to thank you for the excellent presentation and making such a great insights into what is called as HFpEF. I have learned this new terminology today. I have been always calling it heart failure with normal ejection fraction or preserved ejection fraction. But HFpEF is something which is like mind blowing, I would say. I think I will use it more frequently in my practice. But as usual, you always add so much of knowledge to the the subject that I'm telling you that we have learned so much in your lecture today, that how to approach, and very importantly HFpEF score. I think that's a very important addition, which I'm sure my pulmonologist colleague will accept, that it will be easy to adopt in practice. Basically, it's not a difficult thing to do. So Samir, I will ask you this question, that dyspnea out of proportion is for us, the respiratory dyspnea out of proportion, but there is nothing like out of proportion, because COPD patients are breathless and the breathlessness does not correlate with FEV1. That's the worst part of the story, that FEV1 is a very poor indicator of amount of breathlessness in the patient. There may be a person who has no complaints of breathlessness with FEV1 of just 20%, and the another one at 70% is so breathless that he can't barely walk. So like, it's a very poor surrogate marker. So I will ask you that you showed us bendopnea as one of the symptoms, which is very important, and you try to tie your laces and you are not able to do it, you become breathless. That's a classical kind of a bendopnea which you said. But what is about NT-proBNP? Because this is for a pulmonologist it will be very easy to order an NT-proBNP and look at the NT-proBNP. So like 100 or 300, as you showed that in renal failure it gets affected. So is it like sync-non with the normal HFpEF, that NT-proBNP must be high, or it's like there could be conditions where it could be still not high and patient might be having heart failure?
Dr. Thank you so much for inviting me to this session. And I really enjoyed making the presentation and subsequently delivering everything that you talked about. And one thing which I just want to correct, I joined a little bit late in the discussion, but you were calling it diastolic heart failure. So now the cardiology community has gone away from the term of diastolic heart failure, and now we are calling it heart failure with preserved ejection fraction. And one of the reasons for that is that we've come to realize that you can still have heart failure without having diastolic dysfunction. About, I think, 20 or 30% of patients will have heart failure with a normal diastolic function, so to say. And the reason for that is, we've understood that it's that heart failure with preserved ejection fraction, what we call HFpEF in the cardiology community, is a very you have to identify the phenotype of sorts. So even if you have and that is for example inflammation. So there is a school of thought which says that inflammation now causes microvascular and endothelial dysfunction, which over a period of time can cause arterial remodeling that can cause pulmonary hypertension, whether it's obesity or whether it's even COPD for that matter. So there is a school of thought which says that as well. Regarding the thought of NT-proBNP, yes, NT-proBNP does remain a very important marker, but we have to understand that NT-proBNP changes with the circumstance. So if in an older patient, NT-proBNP of 200, 300 is not really going to bother you that much. But an NT-proBNP of 5,000. Now that's a completely different ballgame, right? Renal function affects NT-proBNP. Obesity affects NT-proBNP. I think a few days ago, we shared a common patient, a very obese lady who was on a wheelchair. She had shortness of breath and really bad bronchial asthma, and her NT-proBNP was 200. The question is that was the NT-proBNP completely reflective of her cardiac status or not? Or was it falsely low that you see in renal failure patients? So that is just something to think of. It's not renal failure in obese patients. So that is something to think about when you're assessing the patient, when you're guiding the patient. And I completely agree with what you're saying about an FEV1 not being a completely true prognostic marker of functional status. We have in our clinical practice, what the pulmonology community very commonly understands is the ejection fraction, EF triple, right? There are 90% of the patients with an EF of 35% are walking around. They're doing everything they need to do. They're living a good life. And there are patients with an ejection fraction of 60% who are not able to do many things. And I think we cannot underestimate the value of functional status coming from exercise. And I think that remains of paramount importance. Rehabilitation, you do pulmonary rehab, we do cardio rehab. And I think rehab is very important. So, I mean, there's data to show that if there are two people who have an MI, one is is an obese person who exercises, and the other is a thin person who does not exercise. So the obese person who exercises will do better, will have a better outcome because of his functional status, because of his METs that he can achieve with an MI. So I think we also have to kind of reinforce exercise, reinforce rehabilitation in these patients.
So non-pharmacological therapies are equally important when we manage these patients. And I think, again, you brought a very good, I think, a parallel where we talked about FEV1 not reflecting true status. Even ejection fraction doesn't do the same, which
Not
is a
at all.
news to the pulmonary community, because we think at least that has a very strong marker in comparison to FEV1, because we took almost 20 years to really realize that FEV1 does not correlate with breathlessness of the patient. It took us almost 20 years to realize. But today we are learning even ejection fraction may not do the same, and every parameter has its shortcoming. Madhu, I will come to you with this question. I think if you say,
I want to comment on one thing. There
yeah,
is a prognostic marker. Yes, those patients with a low ejection fraction will have a poorer outcome. I'm not debating that. But in terms of functional status, that is very individual patient dependent.
correct. So even FEV1, which is very low, is a prognostic marker, but not exactly the clinical status of the patient. I think we have a lot of parallels out here. Madhu, he showed that, various phenotypes of this HEPF. There are a lot of phenotypes, and he showed all of them, which we see in our practice in COPD. They are obese, they are diabetic, they are hypertensive, they have CKD. All these things come to us at 80 years of age when the COPD patients come. So how do you actually see this kind of a situation coming up, that it is like tip of an iceberg which we are not able to pick up in our practice?
Yeah, it's definitely we see all this group of patients in our practice. Most of our patients are, we don't see much of COPD patients with obesity as such, because our COPD patients most are lean patients. So some patients with chronic bronchitis component may be obese. Otherwise, most of the COPD patients are lean. But all the other comorbid conditions we see, and how to identify them, how to see the different comorbid conditions in them is a major issue, and how to treat this patient is another major component, which are because we have to optimize the treatment of COPD in them. We have to treat the associated cardiac conditions, and don't forget about hypoxemia, because this is a major factor which may be leading to cardiac compromise as such. So we have to treat the hypoxemia, and when there is a PCO2 retention, I think NIV also plays an important role. So all these components in COPD, we have to optimize the treatment. After that, if the patient is having a significant preserved heart failure, I mean, EF preserved heart failure with the preserved ejection fraction, I think all the treatment like diuretics and SGL, all the newer treatment should be SGL2, T2 inhibitors like dapagliflozin and empagliflozin should be used. I think this is how it goes. Yeah.
Yeah, so I think Samir showed us that, besides the fluid restriction and the diuretics, the most important thing is the new turn which has happened because of the SGLT1 inhibitors. And of course, if the patient is obese, then GLP-1, which is like semaglutide and tirzepatide, both of them do help. I think it has opened a new door besides the non-pharmacological therapies, which are very important, but most often we miss them actually. Most often we miss them. But yes, all these therapies can make a change. I think he made it very clear that ever since this 2021 onwards, the scenario has changed. Previously, there was not much to offer. Obviously, when there is not much to offer, there is not much to chase. But here there is things which you can offer them, you can improve them. That makes a lot of change in the way we think. Anushri, he brought that, the inflammation as one of the reason, which is when it overgoes into systemic circulation, affects the heart, makes the heart affect, and then it is like basically the heart becomes stiff. So, Samir spoke about, the obesity related inflammation, which we all know that it's a very important induced, we have very important inflammation. But we also know that COPD is an inflammatory state where there are so many inflammatory mediators which are flowing into the bloodstream. So in one way, they would be also contributing to that stiffness of the cardiac muscle, which we discussed. So are there any inflammatory markers you use in your practice, like CRP and things like that? Or what is your take on this systemic inflammation coming from lungs affecting heart through the circulation?
Yes, sir. Thank you so much for inviting me as a panelist. To Deepak sir, I must say that we have all been hearing you when even during our PG times, and we're all excited to see your talks on CMEs. So it's very pleasure to share this platform with such eminent speakers and faculties. So coming to the systemic inflammation in COPD, we know that COPD previously it was thought as a core pulmonary disease, but now we say that COPD is a systemic disease because the COPD can affect all the organs via the systemic inflammatory pathway. So the inflammatory markers that I use frequently are the CRPs. I think the ROM guidelines also recommend using the ROM, suggest using CRP as the marker for identifying the acute inflammation in COPD. But the cutoff value is rather questionable because if we see very high CRP values, more than above 40 or something, can say that it is related to some underlying infection or lower respiratory tract infection itself, or the lower levels of CRP as mildly elevated CRP, as in more than 10 to 20, is I think it's questionable. It's a gray zone that we should look for whether it is the underlying infection contributing to the elevated CRP or it is the systemic inflammation that could be the heart failure itself. That I'm not very sure of, sir. But what we have seen is that for those patients with COPD, the symptoms usually overlap. They all start as a lower respiratory infection. They have cough, fever, with history of a viral URTI 1 week back. They all present like that. And in the emergency room, if we do a ABG, can see that the CO2 retention that we usually expect in COPD is not that severe if it is if there is underlying heart failure. And they show a very fast improvement with CPAP support and a short of LASIs. That we are usually saying. I think the ABG is more reliable to look for whether it is a COPD exacerbation or if there is an underlying heart failure. That's just my observation. I don't know if there is any such guidelines saying that.
I think it's a wonderful comment. ABG are essential part of the diagnostic workup of the patients, but we mostly reserve it when the patients get admitted in the hospital rather than doing it on a routinely in an OP patient. And in OP patients, we miss a lot of HFpEF, which Samir has brought in. And when we talked about systemic inflammation, actually he showed interleukin 6 is also responsible. And interleukin 6 is also coming from the lungs. So in a way, I find today a lot of analogies. And one of the analogy goes is the stiff heart and a stiff airways is an inflammation on both sides pouring into the circulation and affecting both of the organs through which the entire blood supply is going. So I think this is definitely an interlinked, and I think that the topic for today was a heart-lung axis or a lung-heart axis, and it has been beautifully demonstrated in this kind of a situation. So Samir, I have one more question, and before I go to that, I will ask you all my pulmonologist panels. HFpEF score, which he has shown, is not a very difficult one. I think this can be adopted in practice, and if we learn that, we might be taking proactive steps, and we might be even pushing the boundaries with our cardiologist that please look into it, that this all dyspnea doesn't appear to be respiratory. There is something more to it. So I think we have this kind of a support from cardiology is required. You need to have a very good multidisciplinary discussion with the cardiologist so that they also understand what is going on with the patient. So you need to give the right inputs to get the right output. That's, I think, the most important message, and that's what is very important what we have seen today. Dhruv is trying to show the lung functions were not bad. So obviously lung functions do not actually indicate much, but there was some evidence to go on. But again, it is very rightly said that you can't only depend upon NT-proBNP. And sometimes routinely on an echocardiography, we may not pick up everything because even they are not suspecting. So it is like, coordination and communication is very good. I will come to one question which has come out today, is that cardiac MRI is actually coming into this field. So Khushbu had brought in a lot of cases of cardiac MRI where cardiac MRI solved the situation by giving us a hint that what is going on wrong, despite our having lot of interactions between pulmonologist and cardiologist in those kind of cases. Even Samir spoke about the cardiac MRI which is coming up. So a quick comment from Khushbu and Samir about role of cardiac MRI. When should we order in our pulmonary patients? Basically, because we do lots of CT scans, but we don't do MRIs because we have been taught in a way that MRI has a very little role in pulmonary medicine, very little role. But now the roles are changing. So what kind of an advice we would like to give to pulmonary community, that where can they use MRI, and particularly this kind of a situation which Khushbu has also brought in. So Samir, first you and then Khushbu.
Yeah. So, cardiac MRI is definitely a test that we order a lot in our practice. I'll tell you some indications for cardiac MRI. Patients who have a reduced ejection fraction, a lot of information you can get out of that. Whether there is scar or not. If there is scar formation, then yes, the patient has a higher risk of arrhythmias. If it's a focus of arrhythmias, then the patient may require an ICD depending upon the ejection fraction. We do cardiac MRIs to try and see if there's any myocarditis. And this is, I'm telling you, the two overall indications of cardiac MRI. Does the patient have myocarditis going on? So you can treat the patient accordingly. If the patient has dilated cardiomyopathy, once again with a low EF, then yes, you would get a cardiac MRI. For preserved ejection fraction, I don't order a cardiac MRI routinely. Maybe I should, but I really don't. There are a few reasons for that. One of that is, what are we trying to look at the cardiac MRI? We're trying to pick up hemochromatosis, amyloidosis, hypertrophic cardiomyopathy, we already pick up on an echo. Amyloidosis, we kind of pick up on an echo, we kind of get an inkling. And there is treatment for amyloidosis and for hemochromatosis. What exactly are we looking for becomes the question. If it's not going to change my management too much, then why am I ordering a cardiac MRI, right? If it's going to not help me too much in my prognostication, why am I ordering a cardiac MRI? For low ejection fraction, there is a lot of information I can get. For preserved ejection fraction, and maybe I will start ordering it, but it will once again be a select group. It's not going to be a blanket thing.
So Khushbu showed us cardiac MRIs of amyloidosis and sarcoidosis patients. So Khushbu, quick comment from you, and then we will go to the questions which were there, and prizes will also be given according to those questions answered. So quick from Khushbu, and then Dr. Dhruv, you take the questions with Dr. Samir. Yeah.
So, sir, just I totally resonate with what Dr. Samir said, but yes, HEPF is an indication because we've seen, sir, not always are cardiologists doing echocardiographies. So, sir, maybe amyloidosis, if you are doing an echo, you may pick up, but otherwise, I've never ever seen anyone report that there is a suspicion of amyloidosis. For amyloidosis, it's an excellent tool where we do pick up it pretty much with confidence, and as you said, it's a treatable condition. So it becomes even more important to be able to pick it up rather than in low ejection fractions where often the scarring and all has happened and we can't do much about them. So there is an indication that we can pick up and treat the patient, and as long as the EF is preserved, the heart failure can be reversed totally.
And
So that,
sarcoid heart.
yes. So such
Sarcoid
sarcoid,
heart is,
amyloidosis, the infiltrative conditions where we can
Condition,
differentiate scarring from infiltration. So when there's active inflammation or infiltration, they're still treatable. So the scarring has set in once, yes, it's not treatable, but in those cases for viability, we do say that whether it will be beneficial to do, the angioplasties, etc. If the heart is completely scarred and gone, there is no need of doing that either. So it's about the viability. Is the heart still viable? Is it reversible? So all of these answers, apart from yes, the structural details. So that's what we get from it.
Even the guidelines do recommend to do in sarcoidosis suspected
Yes, sir.
cases, because that will lead to proactive intervention from cardiologists to put in a pacemaker there, because this patient has a potential life-threatening condition because of cardiac sarcoidosis, not nothing to do with our lungs. So with that, I think we had a wonderful discussion, and we can quickly go to 6 questions which we asked. So Dhruv, just 6 questions.
So the first question was, what percentage of patients with heart failure have heart failure with normal ejection fraction? That's a preserved ejection fraction heart failure. So, sir, I think from your presentation, it's 50%.
Yeah. So I think 40 to 50% of patients, I think all the guidelines and data have also shown this, the various registries, including the Get With The Guidelines registry, has shown that about 40 to 50% of patients with heart failure have preserved ejection fraction. And then there is the 50% who have no ejection fraction.
So this is a mind-blowing figure which tells us that if you consider only the reduced ejection fraction, then you will be missing 50% nearly of them.
Yeah. But we also have to see, Dr. T, that a lot of these patients are also much older. You look at the older phenotype, it's that 75-year-old tiny little lady who's coming in, or that, this 80-year-old person. It's not normally you don't see this in a 30-year-old or a 40-year-old who has an acute MI. So, the phenotype is the patient is different.
Okay. So, Dhruv.
So the second question, which of the following is a key mechanism by which chronic lung disease contribute to heart failure with preserved ejection fraction? Is it direct myocardial damage, pulmonary hypertension, inflammatory cytokine release, or obesity along with insulin resistance?
So,
what's the answer?
So I think it's pulmonary hypertension.
Yeah. So, so I think we talked about the inflammatory cytokine release being a part and parcel, but there are many conditions that cause inflammatory cytokine release, that obesity causes it. One thing I would like to highlight is that, what ends up happening in how pulmonary hypertension develops in lung patients is that, in HFpEF, sorry, is that, when you have your high pressures in the left ventricle and diastolic pressure goes up, it backs into the left atrium. The left atrium then goes into the pulmonary venous circulation, and then through the lungs it goes into the arterial circulation. Now, what ends up happening is that if you have pulmonary hypertension, your RV starts dilating, and when your RV starts dilating, the septum pushes into the left ventricle. So the septum pushes itself into the left ventricle, and then your diastolic function once again goes down. So that is kind of the pathology, the pathophysiology of how lung disease causes FF. The pulmonary hypertension causes the septum to shift, and the atrial dynamics and the hemodynamics change.
So one doubt, sir. So does that mean that all patients with the HFpEF has a pulmonary hypertension in echo?
So not all. Yeah, so doctor, I think that's a great point. People can have pulmonary hypertension, but not always. What ends up happening is that, this is a stiff ventricle. And when you start walking and your heart rate increases, your cardiac output increases. And that is when your pressure, the pressure volume loop that I'd shown, your pressure, your left ventricle pressure, diastolic pressure goes up. And that is when you start developing pulmonary hypertension. So you have only exertional shortness of breath, which may not be because of lung conditions, but it can cause that is when you develop pulmonary hypertension because of that brief period of time. And we see that multiple times. I know that after this talk, Dr. Talwar is going to now start telling me to do diastolic stress tests also. And I can guarantee you that I'm gonna getting a call about this, and Dr. Talwar is going to start laughing. The diastolic stress test you should start, but that is kind of what happens.
Next, Dhruv.
Yeah. So what is the most common symptom which is shared by both the chronic lung disease as well as heart failure with preserved ejection fraction? Hemoptysis, fatigue, chest pain, or wheezing?
So
This
it
one is
is,
simple.
yes, it's fatigue.
Fatigue.
Yeah.
Go ahead. Next.
Which of the following imaging findings is most suggestive of heart failure with preserved ejection fraction? Left ventricle hypertrophy, dilated left atrium, normal size left ventricle with diastolic dysfunction, or right ventricular enlargement?
So, normal sized left ventricle with diastolic dysfunction is a big thing. But I think the dilated left atrium is often underappreciated. In the cardiology world, we say the dilated left atrium is the HbA1c for your left ventricle pressure. So if your left atrium is dilated and you don't have atrial fibrillation, chances are you probably have some element of diastolic dysfunction or left ventricular pressure is high.
In heart failure with preserved ejection fraction, what would be the expected finding on a MRI of the heart? So
This
normal
is Dr. Khushbu.
So
Yeah.
is it, yeah. So is it normal ejection fraction with impaired myocardial relaxation?
That's something which we'll see with echo better. I think normal ventricular size with thickened myocardium. Ideally, we'll see some altered kinetics and abnormal enhancement in the ventricle, which is of a normal size.
Okay. Go
So
ahead.
A
Next.
should be the answer.
Yeah. Go ahead.
What does the left atrial enlargement on echocardiography typically indicate in heart failure with preserved ejection fraction? Is it acute heart failure, diastolic dysfunction and increased left ventricular filling pressure, pulmonary embolism, or aortic valve stenosis?
So this is, like we said, diastolic dysfunction and increased left ventricular filling pressures get the HbA1c of your diabetes.
I think this was a tough question, Samir. So whosoever would have answered it would be definitely getting the Amazon vouchers for that. We will analyze the results and declare it in the next episode. Thank you everyone for joining in and enlightening us in this wonderful webinar, which is linking heart and lungs. And it is something which is, I think, a long overdue for pulmonologists to realize that it is the time they need to realize that what are the other organs doing in the lungs and give a comprehensive care to their patients rather than looking from their own telescopic vision into the lungs only. So we have wonderful discussions. We had Samir, we had Khushbu, we had our panelists who are the eminent pulmonologists across India, and of course Dhruv bringing in a case study where we get confused why the patient is not responding, which is a normal situation, and we find it is a HEFPEF. So the new terminology which Samir has taught us today. Thank you everyone for joining in. In the next episode, we will be declaring the results and giving the prizes to those who have attempted the quiz. I'm told that a lot of people have joined, a lot of people tried the quiz. Let's see, 6 questions were not so easy to answer. So we will be joining back next month with the next PACS in Lung Allies session on some other organ, and as I said, 78 organs means 78 episodes are going to go on air with this. Thank you everyone. Thank you Samir, thank you Khushbu, thank you Madhu, thank you Aziz, and thank you Anushri. Thank you Dhruv for bringing in this. I filled in today for Sushmita. From the next time, I suppose Sushmita will be taking over the episodes. Thank you everyone, and good night everyone from PACS and all the team PACS. Thank you.
Yes. Yes.
Thank you. Oh God, it is gone on for 2 hours. I think we are offline. Are we offline?